Good morning, ladies and gentlemen. For today's presentation, we have Dr. K.T. Prasad. The clinical case is that of a young person with bronchiectasis, and I'm sure that Dr. K.T. Prasad will make possibly the usual diagnosis of central bronchiectasis, that is ABPA. K.T.
Good morning, everyone. Today I'll be discussing the clinical protocol of Mr. PC, a 35-year-old gentleman. He was admitted to our EMOPD last year in November. 4 days after admission, he was shifted to the ward and he expired on the 9th day of hospitalization. Our patient's chief complaints were cough and dyspnea. He was a known case of ABPA, diagnosed at PJ. About 3 months prior to the current admission, he received COVID vaccine. And about 10 days later, he developed fever, dry cough, and pleuritic chest pain. For these complaints, he consulted an outside physician and he started taking some treatment. For the initial 2 months of the treatment, he was possibly doing well. However, about 1 month prior to the current admission, he developed high-grade fever. Simultaneously, he developed productive cough and dyspnea. Expectoration was copious, up to 500 ml per day, foul-smelling and purulent. Dyspnea rapidly progressed over 1 month to such an extent that he was breathless even with day-to-day activities. He had history suggestive of asthma since childhood and was started on inhalers during adolescence. About 7 years earlier, he was diagnosed with ABPA and bronchiectasis in our chest clinic. He was treated with oral prednisolone at that time for about 4 months. He had significant symptomatic relief and reduction of total Ig with this treatment. Thereafter, he was doing well on an inhaler alone till his last follow-up in 2017, except for a single exacerbation in between, which was treated with a short course of oral corticosteroid. He was not a known diabetic. There was no prior history of tuberculosis. He was not a smoker or alcoholic. His family history was unremarkable except for the presence of asthma in his grandfather. About 2 weeks after the onset of his symptoms, he consulted a local physician. Chest X-ray showed a mass-like opacity in the right perihilar region, and a subsequent HRCT revealed multiple areas of mucus plugging and segmental lung collapse. His symptoms did not respond to antibiotics, and as his total Ig was elevated, he was diagnosed with ABPA, exacerbation, and started on oral itraconazole and methylprednisolone. The patient continued to take this treatment for the next 3 months, and the dose of methylprednisolone was tapered every 3 weeks, and at the time of admission, he was taking 16 mg daily. Notably, he experienced worsening of his symptoms 2 months after the initiation of this therapy. At admission to our EMOPD, he was tachypneic with an oxygen saturation of 92% on room air. About 4 days later, he was shifted to the ward, but by this time, he had developed shock and the respiratory failure had worsened. Pedal edema was present, JEP was not elevated, bronchial breath sounds and crackles were noted on auscultation of the chest. Investigations revealed normocytic normochromic anemia at admission. TLC was only slightly elevated. However, marked neutrophilia was observed in the differential count, and during the hospital stay, hemoglobin continuously decreased, reaching 6.6 grams per deciliter on the day of demise. His platelet also continuously dropped, reaching 11,000 at the end. Although the coagularium was initially normal, later the APTT was deranged. Renal function also worsened towards the end. Mild transaminitis was observed throughout the hospital stay. More importantly, his serum albumin was markedly low. D-dimer and fibrinogen were elevated. Urinalysis was unremarkable and spot protein creatinine ratio did not show significant proteinuria. ABG showed combined metabolic and respiratory acidosis prior to the demise. Serum lactate was elevated. Culture of respiratory secretion showed several gram-negative bacteria. Notably, the organisms isolated were not sensitive to piperacillin tazobactam, which the patient received during the majority of his hospital stay. Blood cultures were sterile. Sputum examination for fungi and serum galactomannan were repeatedly negative. However, there was one normal and one elevated report of serum beta-D glucan. Sputum for AFB and mycobacterial culture were negative twice. Total Ig was elevated to over 3,000 international units per ml. HbA1c was elevated to 9.6%. Further, during his hospital stay, blood sugar readings were highly variable, with the highest recorded reading reaching almost up to 400 mg per deciliter. Serum ACTH level was below the lower limit of normal. ECG showed sinus tachycardia. Pro-BNP was elevated, but troponin T was normal. I now invite Dr. Nidhi to discuss the radiology of this patient in detail.
We have 3 CT. The first was done on 2nd September 21. This was HRCT. These are lung window sections which show multiple areas of bronchiectasis which are predominantly central in location with few areas of mucus impaction. You can see here also bronchiectasis with mucus impacted bronchi. In addition, there was an area of collapse involving the anterior segment of the right upper lobe. This area of collapse did not show any air bronchogram, which is the likely cause of this collapse is mucus impaction of the anterior segmental bronchus. There was no pleural, no pericardial effusion, and no significant mediastinal lymphadenopathy. The visualized visualized abdominal sections showed a lesion in the liver, which was showing peripheral nodular enhancement. This is likely hemangioma. So, in view of bronchiectasis in bilateral lungs, mucus impacted bronchi, the mucus was not high intensity, but still the central bronchiectasis and the mucus impacted bronchi points towards the diagnosis of ABPA. The final diagnosis is of course made with a combination of clinical factors. After this, the patient underwent another CT when he was admitted on 27th November 21. As compared to the previous CT, the area of segmental collapse has disappeared. However, there are areas of bronchiectasis in the anterior segment of the right upper lobe. There were multiple areas of consolidation in bilateral lungs with many cavity formation. In addition, there were nodules. Many of these nodules were also cavitating in nature with few central lobal nodules also in bilateral lungs. The consolidation was diffusely scattered, predominantly in the bilateral lower lobes, and the bronchiectasis is also seen at places with mucus impacted bronchi, and few air fluid levels were also seen in the cavities. Better appreciated here. No pleural effusion was seen and no pericardial effusion, no significant mediastinal lymphadenopathy. 5 days later, the CT pulmonary angiography was done to rule out pulmonary embolism. These are the maximum intensity projection images showing no evidence of any filling defect in the main pulmonary arteries or its branches. The mediastinal window sections show evidence of lymphadenopathy, predominantly in the right hyoid and subcrine location. There is presence of bilateral pleural effusion, and the cavities and the areas of consolidation have increased as compared to the previous CT, with many of them showing air fluid levels. Bronchiectasis is seen as seen previously. The cavities have increased in size. So on these CT, we have no pulmonary thromboembolism, we have bronchiectasis, and as compared to previous CTs, we have mediastinal and hyoid lymphadenopathy, bilateral mild pleural effusion. So there were multiple cavitatory lesions and confluent areas of consolidation in bilateral lungs. These findings suggestive of cavitating pneumonia. Etiology of cavitating pneumonia can be invasive fungal or bacterial. In view of the patient having ABPA, invasive aspergillosis is a likely possibility, or it can also be mixed infection with fungal superimposed on bacterial infection. Thank you.
So for the course, in the EMOPD, he was started on piperazine tazobactam, itraconazole and hydrocortisone. Subsequently, when his condition deteriorated, he was started on liposomal amphotericin B and shifted to ward. The very next day, he was intubated and shifted to RICU. In RICU, vancomycin and cotrimoxazole were added, and piperazine tazobactam was changed to imipinum. Liposomal amphotericin B was continued. Despite this treatment, he continued to have fever and the shock worsened. Eventually, he developed AKI and succumbed to his illness. Our unit's final diagnosis was diabetes, bronchial asthma, ABPA with necrotizing pneumonia due to bacterial or fungal etiology. The immediate cause of death being refractory septic shock. To summarize, this was a 35-year-old gentleman with asthma who earlier was diagnosed at PGI with ABPA and bronchiectasis, responded well to oral corticosteroids, and thereafter he was doing well for several years in our follow-up on inhalers alone. There was no history of any infections or exacerbation except for a small asymptomatic exacerbation which was treated with a short course of oral steroids. After that he was lost to follow-up. In September last year, he developed ABPA exacerbation with worsening of symptoms, elevated IgE and mucus plugging. He was treated with itraconazole and steroids, with which initially he had some improvement, but then worsened, this time having cavitating lung nodules. So regarding the underlying condition, I have little doubt regarding the diagnosis of ABPA or bronchiectasis. Both are there. The immunological markers are elevated and HRCT is clearly showing bronchiectasis. Now the question is, which of them came first? whether it was the ABPA which led on to development of bronchiectasis, or whether he had bronchiectasis due to some underlying condition and later he developed ABPA. I feel that the former is more likely because he had symptoms suggestive of asthma, episodic symptoms which improved with inhalers. And in the initial OPD cards, Dr. Ritesh had documented that the involvement of bronchiectasis is minimal. So I feel that ABPA came first, followed by bronchiectasis. If at all he had bronchiectasis initially, generally the bronchiectasis is more extensive and the patient tends to have a more productive cough, which are not in this patient. But we did not do a detailed workup for bronchiectasis. At that time, we were not following a systematic protocol. But for the last 2 years, all patients of our bronchiectasis undergo a detailed evaluation. Now, regarding the current illness, the initiating event was likely to be ABP exacerbation. He had worsening symptoms, IG was elevated, and his initial chest X-ray had shown a mass-like opacity, which on subsequent treatment with itraconazole and steroids had cleared up nicely, leaving only areas of bronchiectasis. Now, despite being on itraconazole and oral corticosteroids, later he worsened with the development of cavitating lung nodules. Now, for cavitating lung nodules, the differentials are wide. It could be infectious or non-infectious. For this patient, I would favor infectious etiologies over the non-infectious ones for the following reasons. First, rapid progression of the opacities. So this is the X-ray at his admission, and this was just 10 days earlier. Although the process has started, there were some cavities over here, and even in the retrocardiac areas, we can see some densities. But over a span of less than 10 days, multiple nodules and mass-like opacities have come up with cavitation and air fluid levels. So this sort of rapid progression is generally associated with infection and less common with malignancy and rarely with vasculitis. Pulmonary embolism was anyway ruled out. Now, second thing is that he had several risk factors. He had bronchiectasis, which could predispose to colonization with both fungi and bacteria. He was not a known diabetic, but he had uncontrolled diabetes with very high blood sugars, and he was also on oral corticosteroids. So collectively, all these factors could have depressed his immunity significantly. Now, if you think that all these factors which I have listed is not sufficient, there is one more hidden factor, which is itraconazole. So itraconazole, you might think that it might be protective against fungal infection, but unfortunately it is not. Itraconazole is not a very active agent against invasive aspergillosis. It may be useful for ABPA and CPA, but for invasive aspergillosis, it's not a very good agent. Also, it has a peculiar interaction specifically with methylprednisolone. It inhibits the hepatic metabolism of methylprednisolone and causes significant increase in the levels of methylprednisolone, markedly increasing the amount of immunosuppression. Fortunately, this interaction is not seen with prednisolone. So that's why any patient we treat with itraconazole, if we are using steroids, we use prednisolone rather than methylprednisolone. But this patient was treated outside and he was taking these two drugs. Now, my first differential would be invasive pulmonary aspergillosis. Apart from the predisposing factors and the radiology, unfortunately, the only thing which supports me is a positive beta-D glucan, with that too was one single report. And there are several factors which are stacked against my diagnosis. But still, on a closer look, I felt that these points were not very strong. For instance, halo and air crescent sign, which are common in patients with classical risk factors like hematological malignancy and post-transplantation. So these are not very common in patients without these factors. Similarly, smear and culture of sputum and serum galactomannan, they also have a very poor sensitivity in those patients without classical risk factors. Also, BAL and invasive sampling, which have a better sensitivity, could not be done in this patient. And although this patient was given amphotericin B and he did not respond well to liposomal amphotericin B, the reasons being he had a very late presentation. By the time he came to us, there was extensive lung opacities. Amphotericin B could be started on day 4 only, possibly because of financial reasons, I am not so sure. And he had definitely secondary infection due to multiple organisms, and culture subsequently showed that the initial empirical antibiotics which were given to him were not appropriate. The organisms were resistant to the given empirical antibiotics. So this case has a striking similarity to a previous case report which had reported a few years back. This was also a case of IPA in ABPA. In this patient also, methylprednisolone and itraconazole was given by an outside physician. Only the dose was slightly different. And these are the baseline X-rays of that patient and our patient, almost similar. And importantly, if you see the radiology, they are strikingly similar. Multiple nodular and mass-like opacities and cavitation, very similar. Now, mucormycosis can have a similar presentation. However, such extensive involvement of the lungs goes against it. And the positive BDG is not generally seen with mucormycosis. It is more commonly associated with invasive aspergillosis. Now, nocardiosis can have a similar picture. And this patient was also not adequately treated with cotrimoxazole. He received only 1 or 2 days of cotrimoxazole. However, again, there are certain factors. Again, nocardiosis, mediastinal lymphadenopathy was there. Extensive pulmonary involvement and aggressive clinical course is generally not very common with nocardiosis. And septic emboli, there are several factors against it. Clinical examination of CVS was normal. He did not have any predisposing factors like IV drug abuse or valvular heart disease, and blood cultures were negative. Secondary bacterial infection with lung abscess, definitely it is there because he had copious expectoration and sputum has been documented as up to 500 ml per day. Such an amount of expectoration is possible only with mostly with lung abscesses, and there were several cavities showing air fluid levels. Multiple organisms were isolated and the antibiotic given were not appropriate as per the culture. So there are no points against secondary bacterial infection. Now, other abnormalities, there are several abnormalities. I'll not be able to explain them in detail, but definitely he had bicytopenia, which was more profound towards his demise. Both DIC and hemophagocytic syndrome can explain it. However, the workup for hemophagocytic syndrome was incomplete. Triglyceride and ferritin are not available, and an elevated fibrinogen goes against the diagnosis of both DIC and HPS. His albumin was markedly low, only 2 grams per deciliter at presentation. Although acute phase reaction can explain some of the fall, but it cannot explain such a severe fall. He did not have proteinuria, and I feel that the loss of proteins in his sputum, he was producing copious amount of expectoration, could have contributed to his hypoalbuminemia. He had mild transaminitis with ALT more than AST. He could have had fatty liver secondary to metabolic syndrome or steroid use. Elevated LDH is likely sepsis related. The liver SOL was stable in the subsequent scans, so I feel that it is a hemangioma. Bilateral pleural effusion is possibly translative because he had pedal edema as well and severely reduced albumin. Elevated pro-BNP has been described in septic shock even in the absence of cardiac dysfunction. Rest of his cardiac evolution is unremarkable. He definitely had AKA, possibly related to acute tubular necrosis related to the shock. And as expected, his ACTH was markedly suppressed because of exogenous administration of steroids for quite a long time. So in summary, my final diagnosis will be the underlying diagnosis asthma, ABPA as the primary abnormality, which resulted in bronchiectasis. The antecedent cause of death, the factor which initiated everything was an ABPA exacerbation, but subsequently it was a treatment-related complication with invasive aspergillosis, lung abscesses secondary to gram-negative bacterial infection. Complication, he possibly had DIC or HPS, and he had sepsis-related ATN, and the immediate cause of death is refractory septic shock. Thank you.
Thank you, Katie. Please come and join me here. So naturally, we are dealing with the patient who has got 3 main issues. One is that of bronchiectasis, second that of allergic bronchopulmonary aspergillosis, and third is secondary infection, which is bacterial or fungal. So with these comments, now I'll invite if somebody wants to add something. The first is the cause of bronchiectasis in young. I'm sure that I can see the hands from pediatricians, and they will talk about immune deficiencies, CVIDs. Yes, please. So could it be CVID, cystic fibrosis?
I don't think this is ABPA. This patient looks like a prototype of chronic granulomatosis disease. He's symptomatic since early childhood. Elevated IgE, Stenotrophomonas, Burkholderia, these are like signature organisms of CGD. And even the globulin fractions, or whatever reports we have, are on the higher side. In addition to the aspergillus, I'd also like to cure possibly nocardiosis in this patient. And as far as the beta-glucan, which the presenter has been highlighting, this patient has received PIPTAS, so it could be falsely positive too.
Yes. Any additional finding rather than... So he says CGD, not CVID. CGD, does it produce bronchiectasis?
Yes, CGD can produce, we have seen cases. And moreover, there is a liver lesion. So it can be granuloma, and the pattern of organisms, these gram-negative organisms are Stenotrophomonas, Burkholderia, aspergillus, and Acinetobacter. And neutrophilic predominance and the bicytopenia with transaminitis, this can be HLH or can be due to sepsis.
I thought that somebody would comment on it, definitely on cystic fibrosis. Yes, Ritesh. So would you please also comment on the spectrum of aspergillus, that, the types of aspergillus, because, people confuse with ABPA, with colonizers, with invasion. So please comment on that.
First, regarding the immunodeficiency, well, it can be CGD, it can be anything, but it looks odd because the patient from 2014 till 2001 had no other infection, received steroids and anything. In clinical setting, if you keep suspecting immunodeficiency, you will find immunodeficiency. Some genetic mutation here, some genetic mutation there, some markers low, some markers high, but that doesn't mean immunodeficiency. Immunodeficiency should have a clinical pattern, which was not seen in this patient. If it turns out, it will be a surprise. It will not change our clinical practice. With this kind of clinical presentation, what we will do, we'll continue to do. That is point number one. Secondly, this patient had ABPA to begin with. That is certain. The patient had raised specific IgE, raised total IgE, bronchiectasis, mucus plugging. That is ABPA. No doubt about that. Given steroid, completely improved, doing well. Now, the situation after that has been clearly explained by Prasad. He has clearly described the reasons which has led to the development of infection, and which is typified by what we call as the net state of immune suppression. So you have a patient with ABPA, there is aspergillus, we give them steroids left, right and center, they do not develop aspergillosis, but there are settings which lead to the balance being tilted towards the invasive side. One is development of intercurrent viral infections, say COVID, H1N1, etc. Second is high doses of steroids. Some people use methylprednisolone, and that can cause. The third is the combination of methylprednisolone and itraconazole. So that I possibly tilted the balance. However, having said that, bacterial infection is definitely there. In invasive pulmonary aspergillosis or in chronic pulmonary aspergillosis, copious sputum more than 100 ml, etc. is never seen. It is a rare thing, and if it is seen, it is mostly secondary bacterial infections.
Yes.
Cystic fibrosis seems very unlikely. The bronchiectasis in the initial phase was minimal, and that's why we were thinking it's primary ABPA. So you can classify ABPA into a de novo ABPA and a secondary ABPA. A secondary ABPA is one which occurs secondary to some other etiology, say ciliopathy, cystic fibrosis and so on. And then you have de novo ABPA where there is no genetic mutation. The patient has an aberrant type 2 response to environmental aspergillus, and which tilts the balance towards an increased type 2 response.
Yes. Any other comments now? Yes, one other possibility of ciliary dyskinesia. Yes, in there. Would you like to comment that it was primary ciliopathy, that means ciliary dyskinesia, and then aspergillus sensitizes individual? See, at this stage, short of ultra structure, I'm sure, I don't know whether Dr. Aman would show us or not.
Well, I would agree with sir that probably this is a de novo ABPA because this patient did not have anything to suggest even upper respiratory tract symptoms. So if you have ciliopathy, generally you would tend to have chronic sinus symptoms also. And the kind of bronchiectasis that we see in ciliopathy is slightly different. You see extensive involvement of bilateral middle and lower lobes, which was not there at least in this case. So I think this is not a ciliopathy, at least clinically.
It is primarily middle and lower lobe, but the only point is it's central.
the thing is, sir, it is not that extensive. And if you see ciliopathy, then you need to have some. It was not there. It is not the usual kind of CTs that we see in ciliopathy. So the bronchiectasis to begin with was not very extensive. So I think that is a point against anything like cystic fibrosis and ciliopathy here.
Yes, any other comment? But if you ask me, this is the most extensive bronchiectasis one can come across. And there are multiple abscesses which are for sure, which are lung abscesses. So, yes, any other comment? Any cardiologists, any? Yes. What about pulmonary arterial hypertension?
I don't think. Sorry to come back again. I just wanted to clarify. The first one is a bronchiectasis. The second CT is not bronchiectasis. That is development of acute cavitation. So that is necrotizing infection which has caused a cavitation. So please don't think that the bronchiectasis is extensive. The bronchiectasis is minimal. The patient developed infection and has developed cavities. So the extensive nature of involvement the second time is cavities.
Yes, and for the same reason, pulmonary hypertension was not there. So if the patient had extensive bronchiectasis, then generally the patient would have developed pulmonary hypertension by this time.
Yes. Would anybody else like to comment on? Yes, Vignesh?
In pediatrics, we give more importance to the anthropometry. I don't know what is the height and weight of this patient. If this patient is severely emaciated or malnourished with severe hyperalbuminemia, some chronic disease, but definitely going on. Simple ABPA, I don't think it will produce severe malnutrition or stunting. That is number one. And number two, we have seen patients with ABPA turning into CGD with the extensive bronchiectasis. The management do change. We do initiate prophylaxis and they do remain free of infections once we start on prophylaxis.
Yes, Nidhi, would you like to comment now the question of, yesterday also we were discussing about radiology is not only for the diagnosis, it's for the extent of the disease as well. So would you like to comment now the cause of the bronchiectasis for sure, you can say, or like you said that you have to add clinical factors to that. So what do you have to say if you have to pick up a chart?
So bronchiectasis pattern is more like ABPA in this. That is why I said first, but obviously we need to correlate with the IgE levels. In chronic granulomatous disease and cystic fibrosis, you have bronchiectasis which is more scattered and more multifocal. Here the pattern was less and more in the central location. And secondly, I would also like to add one point about the halo sign. Halo sign is seen in patients of angioinvasive aspergillosis or aspergillosis which comes through the vessels and then forms a halo. But in ABPA, in this kind of this thing, we expect an airway invasive aspergillosis. So halo sign may or may not be seen.
Yes, Katie.
Since his albumin was very low, I had looked at his past albumin level also when he was following up with us. At that time, it was normal. And there was also no records or documentation of diarrhea or any signs of malabsorption.
Yes, and Ig levels to aspergillus is 14,000. Definitely is highly sensitized to aspergillus for sure. Yes, if there are no comments, then I would request Dr. Amanji to show us the pathology.
Thank you, sir, and good morning, all. So in this 35-year-old male with the clinical diagnosis of bronchial asthma, allergic bronchopulmonary aspergillosis, necrotizing pneumonia, query bacterial, query fungus, along with diabetes, a partial autopsy was performed and prosector has written that patient was moderately built and height was 178 centimeters. Each pleural cavity yielded 500 ml of straw-colored fluid. However, pericardial and peritoneal cavities were within normal limits. So starting with the lungs, both the lungs were heavy. They weighed around 2.5 kgs, and this is the posterior aspect of the lung where we see there is dullness of the visceral pleura and there are multiple nodular lesions which are bulging from the pleural surface, and both the lower lobes as well as in the right lung the upper lobe was also involved. This is from the anterior surface. Here also we can see multiple small nodular lesions, and they are much more prominent on the posterior surface as compared to the anterior surface. from the pleural aspect, and tracheobronchial tree was clean, did not show any erosions or ulcerations, and the upper lobe of the right lung was decorticated while removing, because prosector has mentioned there were a lot of adhesions with the chest wall. Now coming to the closer view of all these lesions which were bulging out from the pleural surface. So these are large necrotizing lesions. So this is the largest one, measuring around 8 into 5 centimeter. And then we have smaller lesions also which are breaking down, and they are filled with central yellowish pus. Similarly, in other side also we have varying sized nodules. Majority of them are breaking down with cavitation, and they are scattered throughout the lung parenchyma in both the lungs. This is a closer view to show the large cavities with central necrosis. And some lymph nodes were enlarged, which were dominantly showing anthracotic pigment only. There were no areas of necrosis in the lymph nodes. In other areas, there were smaller nodules. Intervening lung parenchyma showed hemorrhagic consolidation. So these are the representative microscopic images from different necrotizing lesions, and because most of the lungs were dominated by these cavitating lesions and preserved lung parenchyma was very few. So this is one of the cavity which is close to the pleural surface, and the pleura also showed presence of fibrinoid pleuritis. So there are multiple nodular lesions which are breaking down in the central area, which shows like infarction necrosis bordered by this type of necrotizing inflammation. Another area showing these necrotizing lesions. This is a closer view. So mostly these lesions are composed of inflammatory infiltrate dominated by neutrophils, which we see here, and a mixture of macrophages. At this time point, there was no excess of eosinophil noted, and within these necrotizing areas, fungal hyphae were not appreciated. Other areas, mostly they were like nuclear debris or degenerated cells, and in the periphery we have presence of these fibrin balls in the air spaces. This is closer view to show just nuclear debris and some preserved neutrophils, and center is showing infarcted parenchyma. Periphery of these necrotizing lesion, fibrin balls, which are better appreciated on this high power. In other areas, these large cavitating lesions bordered by fresh alveolar hemorrhage. This could be a terminal event in this patient, and the vessels which were entrapped were showing changes of secondary vasculitis. And relatively preserved area showed this type of bronchiolocentric necrotizing lesions. PA stain was done on multiple sections to look for fungus. However, there was no evidence of any fungus, neither aspergillus nor mucor, in any of the sections examined. This is Gram stain, where we find numerous delicate branching filamentous organisms, and they are plenty, and they were seen in almost all the center of all the necrotizing lesions. This is under oil immersion, where we can see these branching filamentous bacteria which are around 1 micron in thickness. This is Grokert stain to highlight these filamentous structures better. This is again closer view to show these branching filamentous thin organism, and this is under oil immersion. And this morphology both on Gram stain and Grokert stain is consistent with nocardia. So what we are seeing is all these necrotizing abscesses are because of nocardia. So we have extensive pulmonary nocardiosis. Sorry. The relatively preserved lung parenchyma showed presence of this type of hyaline membrane along the alveolar duct, so which is indicative of diffuse alveolar damage. So this is again to show a hyaline membrane, some interstitial edema. Okay, now coming to the bronchiectasis part. So as has already been highlighted by radiologist and the clinician, that bronchiectasis was minimal and central in location. So this is not the bronchiectasis which we usually see in cases of cystic fibrosis or primary ciliary dyskinesia. Only the central or the proximal bronchi were dilated and showed some thickening of the wall, but as we are going away, there is no thickening of the wall, there is just a dilatation of the bronchi. So this is again a closer view to show only the proximal one was showing thickening of the wall of the bronchi. So this is the morphology, what we see in these bronchi. So lining is more or less ulcerated. Lumen is showing presence of mucin along with some inflammatory cells, but it's not like a classical allergic mucin, what we see in ABPA. No Charcot-Leyden crystals or no fungal hyphae were seen in these areas. What was prominent was thickening of this smooth muscle, which is around 2 to 3 times what we see in a normal bronchi. So this is just a normal control to show you that this is the smooth muscle element which is seen in a proximal bronchi, and this is the amount of the seromucinous glands which we see in a normal bronchus. But here we see the lining is ulcerated, this much is the smooth muscle, and then we have extensive increase in the seromucinous glands of the bronchial wall. This is again the closer view to show the increased number of seromucinous glands. And there was these mucinous diverticula, which are nothing but just a dilated bronchial gland ducts which appear as diverticula. So this is a PS Elchin blue stain which is highlighting the presence of Elchin blue positive mucin, which is coming out from the dilated opening of the duct. In addition, there was increase in the goblet cells. This is PS Elchin blue, which is highlighting the number of the goblet cells in the ciliated columnar epithelium. Normally, in a normal bronchus, they should constitute only 5 to 10% of the lining epithelium. But here, it's, I think, certainly more than 20% of the lining epithelial cells. Going slightly towards the distal airways, these also showed lot of thickening of the smooth muscle. In the distal airways, the smooth muscle is not that prominent. However, there is hypertrophy of the smooth muscle in the distal airways also, and some amount of inflammatory infiltrate in the wall, which is again lymphocytes and some plasma cells, but not enough of eosinophils. And even in the distal airways, there is some amount of ciliated columnar lining epithelium, while in normal distal airway, it should be low cuboidal epithelium. So, and this is the amount of secretions which were present in the lumen of some of these bronchi and bronchioles. So, nothing to suggest ABPA at this time point. Whole exome sequencing was done in this case because I knew there will be lot of questions, but probably this has not yielded any answers. So first, all these which are in black are associated with susceptibility to asthma in these patients. There were variants which were noted. Those had RSIDs, but they have not been reported of clinical significance in ClinVar. Then there are two alterations which I thought would be important. One is STAT6, which is responsible for increased IgE levels and increased eosinophilia in patients of asthma, and this is in the UTR region. But this also has not been reported of clinical significance in ClinVar, but other variants have been reported in association with asthma and increased IgE and eosinophilia. There was a molecular alteration in DNA H11 gene, which is a heavy dynein arm, which is associated with primary ciliary dyskinesia, and this was reported as of uncertain significance in OMIM, but it was a heterozygous mutation. So since there was alteration in this, so we did immunofluorescence for ciliary proteins. However, almost all the proteins were retained. This is beta tubulin for internal control, and red color represents different ciliary proteins. And this IF was done on paraffin sections. So this is on merging the yellow appearance. So all the ciliary proteins were retained. But when I was going through literature, they say that DNA H5 alterations, they do not change the structure of the cilia, or they do not cause loss of proteins. They just cause changes in their kinetics. So cilia are stiff and static, but they are structurally normal. EM was attempted, but because of poor quality of the sample, these are degenerated ciliary proteins. However, only I can show you is preserved 9+2 arrangement in these cases. STAT6 I have already highlighted. It's associated with changes in the asthma. Now coming to other organs, we have liver weighed 1200 grams, spleen 120 grams, pancreas was grossly normal, it was not fibrotic, maintained lobular architecture, some fat was there, but what we see here is dilatation of the sinusoids in the centrizonal area and some cholestasis in centrizonal area, which could be sepsis related. A lesion which was noted on CT is nothing but hemangioma, which is confirmed on microscopic examination. Spleen showed relative depletion of white pulp and red pulp was congested. Pancreas showed normal acini and islets, and there was no fibrosis or features to suggest cystic fibrosis in the pancreas. Kidneys weighed 280 grams, and both the kidneys had superficial cortical scars. This is the cut section, and there were these tiny soft lesions which were present in the cortex. And this is section from that lesion which shows abscess similar to what we saw in the lung parenchyma. Tried to look for nocardia in this, only I could find this structure. Not sure whether this represents nocardia, but certainly these are infective in etiology and they are abscesses secondary to some bacterial agents. In addition, the tubules showed presence of this type of casts, which are pigment or granular casts, and some hyaline casts were also there, and there was dilatation of the tubules which indicates acute tubular injury. These casts were PS positive, and those granular casts were, or pigment casts were positive on MSB, and these were actually the myoglobin casts which were causing injury to the renal tubules. The glomeruli were unremarkable. There was no fibrin thrombi in the glomeruli. Heart was grossly unremarkable. Valves were within normal limits. No vegetations were noted, and microscopically did not show any evidence of myocarditis. Another finding in this case was one testis was normal. So this is the corresponding histopathology. And other testis was small in size, and it showed marked atrophy of the seminiferous tubules, and there was decrease in the sperm counts and spermatozoa within these seminiferous tubules. So the one molecular variant in DNA H11 has also been associated with infertility in males, and that is because of the low sperm counts, defect in the mobility, and abnormal shapes of the spermatozoa. Adrenal glands, there was relative cortical atrophy, and there was presence of these fibrin within the sinusoids, which could be because of DIC. GI did not show any significant pathological findings. Marrow was normal cellular for age. However, there was some excess of histiocytes with erythrophagocytosis, but it was not a dominant finding, so I'm not putting this as a secondary hemophagocytosis in my final slide. Thyroid was unremarkable, and skeletal muscle, which is a psoas muscle, did not show any significant pathology findings. So in a 35-year-old male, there are histological features which are suggestive of bronchial asthma, but at this time point, we did not see any changes or features of ABPA. There is pulmonary nocardiosis with diffuse alveolar damage and hematogenous spread to kidneys in form of old superficial cortical scars and small abscesses. Severe acute tubular injury with myoglobin casts and incidental cavernous hemangioma of the liver. Thank you.
Thank you, Amanjeet, for showing us a brilliant pathological disposition. Now, it's very interesting that many times not only the positive, even the negative findings have great clinical significance. And these type of patients require combined efforts from both clinicians, pathologists, those who deal with immunological phenomena to come to a final conclusion, because, that's a matter of understanding. Because absence of a cell, does it point towards a diagnosis? Does it really exclude once the person has received so much of steroids? Because these are the points, and here comes the importance of your experience with the clinical situation. But what strikes me is, testicular atrophy. So I was just looking at the family history, a simple history like whether he was married, whether he has got children, because we know the classical young syndrome has got azoospermia, sinusitis, and bronchiectasis. So, very unlikely to be having so, but the story cannot end here, because, you can always contact the family to find out what exactly is happening. And maybe now, Ritesh, can you still say that eosinophils can disappear to zero with steroids and so on? Because we know steroids are very strongly
There is no bronchiectasis, but you should bronchiectasis on the pathology. You said the proximal was thickened and all dilated. I thought bronchiectasis was conspicuously missing. There's bronchiectasis on the CT and there's no bronchiectasis on the pathology. It seems very odd. And the bronchiectasis on CT is not, some minimal bronchiectasis. It is significantly enlarged bronchi. So I think that is one point which is missing.
And
so
the mucus plugging with the
so
collapse.
you don't have pathological evidence of allergic bronchopulmonary aspergillosis, but you don't have pathological evidence of bronchiectasis too.
I have not put it in the final slide, but there was evidence of bronchiectasis, which I showed, which is only the proximal part. It's not that diffuse going to the pleural surface, as probably it's correlating with the CT also.
Okay, so there is bronchiectasis, isn't it?
So I wanted to ask you whether can we differentiate bronchiectasis from bronchial dilatation, which gets reversed? In the initial CT, it was there. In the subsequent CTs, it was not there.
See, there are areas which are fixed bronchiectasis, which were there in both the CTs. So bronchiectasis is definitely there. There's no doubt about it. And the point is, EBPA can become quiescent with steroids and itraconazole. And given the high levels of steroids which the patient has received, you can have a completely asymptomatic, completely normal lung anatomy and histopathology. So not anatomy, I mean lung pathology. The other point which I wanted to ask was the exome sequencing. So you're trying to say that because you are going on discussing about those cilia, stiffness and all, this patient is not ciliopathy of any type. So if you do mutations, if you do whole exome sequencing in patients with asthma and ABPA, you will find heterozygous mutations left, right and center. And that's what I was trying to tell my pediatric colleagues also. So if you do mutations, you'll find some heterozygous mutation here and there. But that doesn't make it a clinical presentation. The clinical presentation is that only. The clinical presentation is what we see that. This is ABPA. I mean, whether you show it on pathology or not, that is irrelevant to us that way. The other point is that heterozygous mutation means nothing to us unless there is double heterozygous mutation or something.
So I agree with you. The exome sequencing data which I have shown, so I have said no pathogenic variant, so that's why I have not called it PCD. So nothing to suggest pulmonary ciliary dyskinesia in this. Those molecular alterations probably might have contributed to mucus stasis and subsequent infections in this patient.
Yes, Saijal. I think now I have to invite all the time genetics, to a pathology and so on, because it becomes so important. And we are shown so many, heterozygous clinical variants of significance, no significance. I'm really,
Ma'am, you said that one testis was normal, the other had atrophy, and you are correlating it with the ciliary dyskinesia kind of thing.
Oh, she's
but
not
why
telling
should
me,
it be?
she's showing. She's just showing.
No, but you propose that. Why should it be unilateral? It has to be bilateral if it is a genetic disorder. The unilateral atrophy may be something like, it may be an undescended testis, or it may be trauma, or it may be anything else.
So it
Well,
was
Saijal,
not,
she can't answer. We have to answer as clinicians.
I'm just asking
Can it
whether
happen?
a genetic abnormality can lead to unilateral absence of seminiferous tubules or reduction. One testis is normal.
So other testis is also not totally normal, and it's certainly not undescended testis because it was present in the scrotum only, as said by the prosector. So other testis did show decrease in spermatogenesis.
Well, I can say always, why should a patient with bronchiectasis have a testicular atrophy? So the reverse can also happen. So we have to correlate actually what is the best evidence. That's where, many times all these things cannot be answered just on pathology or ultrastructure. What we can see is, and then we have to use our brains. And I'm pretty sure about it that if we sit together, possibly we can come to a conclusion.
So I just want to ask
sure.
one question. Why this is not a bronchial asthma alone? Why we are thinking of ABPA along with bronchial asthma?
Yes, Inder is getting excited now. Inder.
He had a history of bronchial asthma. Secondly, there was clear bronchiectasis on the CT. Third, serologically, it was satisfying all the criteria for ABPA. So clinically, it remains ABPA. It is interesting that there is almost no bronchiectasis on the pathology, which I cannot explain.
No, there is.
It is there, but it's only limited, and the proximal
Is
part
it there
of
or not, ma'am? There is.
It is
So
there, I
there is.
showed
So it is ABPA with bronchiectasis. What is the problem in accepting that? Not by you, but by others.
I mean, do you want to make ciliopathy or you don't want to make ciliopathy?
No, I have not made it
So I think
ciliopathy.
we are on that level ground first. Okay. So there is no ciliopathy. If at all it is there, it is hypothetically possible that a heterozygous mutation could lead to stasis. These are all hypotheses. It is not yet proven at all. Even in the, you have to prove a video microscopy, some knockout model, whether it actually leads to it. Otherwise, heterozygous mutations don't cause any abnormalities. Patients live normal with that. That is point number one. Point number two, this patient had asthma. Asthma is a clinical diagnosis. You have shown some pathology finding also. Even if they were absent, it would be asthma. Second, the patient has bronchiectasis, CT and pathology. The patient has immunological findings of ABPA, so ABPA is there. Whether you've shown pathology or not, that is immaterial to us. So that point is clear from our side. Now, what has happened to it, you have clearly showed. We missed the bus. We kept that a second possibility. We were discussing yesterday. Why Prasad was going on telling, sir, I don't think aspergillosis kahin se bhi nahi aaya. So he was going on telling, kahin se bhi nahi aaya. And I was saying, nahi, look at the CT, that CT. So I biased him, I think, towards aspergillosis. Otherwise, he would have made nocardia itself.
Yes. You still persist with CJD? Because here we are discussing what is not seen.
Nocardiosis was there, but another thing in whole exome sequencing, there was on STAT6 variant. So heterozygous mutations doesn't always mean that there is no pathogenic variant. Gain of function, heterozygous variant of STAT6 has been previously described with allergic disease, because STAT6 is the transcription factor which produces IL-4, and IL-4 will drive T cell subsets to Th2 pathway. So to prove pathogenicity or not of mutation, we'll have to run in silico prediction tool, we'll have to test the parents, we'll have to do functional assays. And it has been described, heterozygous gain of function of STAT6.
So
Do
that's
we have
why
any genetist who can, or maybe you can answer?
So that's why I highlighted only those two which might have contributed maybe 5% or 10% to some clinical features in this patient.
Yes. Yes, Arya. You know, there are departments now which are being developed, which is called departments of precision medicine. And that's exactly what they're trying to do, is to, personalize, because many times we believe that they are strict compartments. Infection, immunity, genetics. I believe there's a lot of overlap which happens, and what is the basic disease, what excites them, what actually produces the stimulus, and what is the end result. Because what we see is only the end result. Yes.
Sir, जैसे like Dr. Ritesh was saying कि aspergillus कहीं से भी नहीं आया. My question is, very frequently we are seeing nocardiosis being diagnosed on the histopathology specimens. This patient had like 5 or 6 sputum samples, was producing 500 amount of sputum, and we had done all sorts of staining, fungal smears, modified AFB smear. There are senior microbiologists sitting here. Why was nocardiosis not isolated antemortem is my question.
Yes.
See, there is modified AFB, we did not ask. So we have to accept our gram strain.
In the sense that one should give credit to everybody. It's not that why was it not seen. In the sense, I'm pretty sure about it that they would have done gram strain, which is the first thing to do.
No, I mean, had it been there, gram strain would have picked it up. But in a chronic compromised lung, which gets colonized with multiple other organisms like Burkholderia, Stenotrophomonas, Pseudomonas, Acinetobacter, which are far, far more faster growing than nocardia itself. On culture, the nocardia is usually overgrown by those organisms. So they don't allow them, because nocardia is slower growing. But had it been there on grams, in the specimen, the amount of specimen which has been used for the gram strain, definitely with gram strain, it should have been picked up. We don't need a modified. That's to confirm it. But we pick it up with gram strain.
I just want to ask, suppose you put up a sputum for culture, and nocardia is there. In the sense that, will it be grown, not grown, or what exactly?
Yes. Unless the specimen is grossly contaminated with other faster growing organisms, it will definitely grow. From blood, we never miss nocardia, because it's otherwise a sterile sample. So here, if there was an FNSC sample from the affected areas, nocardia would have definitely been picked up and cultured. But sputum itself, or other types of, except for protected bronchial brush, all other respiratory specimens are considered to be more than minimally contaminated.
All right, and there is no confusion about this filamentous structure because 2 weeks ago there were a lot of, yes, all filamentous structures are not fungi, all filamentous structures are not bacteria. So, anybody else would like to comment? Katie, would you like to? But finally, so what is because clinicians are putting like Angar, this is ABPA, the pathologist says is asthma. So where do we join hands? Oh, Wali, you wanted to say something? Or you are supporting your colleagues?
Regarding the genetic testing, I think in the coming days we'll be seeing more and more of these investigations in pathology, as you had been saying. But having said that, all diseases, including depression, suicide, everything has a genetic basis. So this being an immunologic disease, a genetic basis is likely to be there. So I think that alone would not make it a pathogenic variant unless we, in life, if we can prove that there is any functional dysfunction due to this mutation. So that would be another way that if somebody is having repeated heterozygous mutations, we can get a functional assays of all these things, and beyond, without that, it is difficult to say whether it is abnormal or not.
Everything would have a genetic basis. Now is becoming confusion. How can environmental pollution have a genetic basis? So, in the sense that
pollution cannot have a genetic basis, but those who pollute can have a genetic basis that they are pathologically destined to pollute the environment.
It's all right. Okay. Yes. Well, any other, so that the idea is to come to a conclusion actually and some unifying hypothesis.
Just for the residents, I would like to reiterate, as Dr. Ritesh has already pointed out, and there was a comment that sometimes ABPA gets converted into CGD, which I didn't understand. Basically, it may be a background of asthma over which ABPA develops, which leads to bronchiectasis. So that bronchiectasis, as Dr. Ritesh mentioned, is kind of a primarily ABPA, and that bronchiectasis is primarily due to ABPA. So the other way that ABPA can develop is that there is pre-existing bronchiectasis, and then aspergillus sensitization occurs, and that develops into ABPA. So these are the two major categories of ABPA that we see, and I just wanted to clarify.
Yes, Dr. Sujit.
I think the provocation is extreme. Two signature organisms for CGD. Burkholderia and Stenotrophomonas, and then a third signature organism, Nocardia, on pathology. CGD has to be there. Whether ABPA is there or not is a moot point. It may be there. You are fully justified in treating for ABPA. But three signature organisms for CGD being present in the same patient, I mean, it's too much of a coincidence. I can't swallow that. Vignesh, how many patients of CGD in your series had Stenotrophomonas? You can come here and tell that. And it's very easy to rule out CGD here. I mean, if the parents are alive, we can still make the diagnosis of CGD here by doing a simple flow cytometry. So there's no problem in diagnosing CGD. I mean, had this patient been worked up for CGD, the diagnosis could have been made in 1 hour. Vignesh.
Yeah.